Hopefully, the interesting topic of the day is psychiatric adverse effects of quote-unquote medical medications. I don't really like the distinction between medical med and psychiatric med. I get where we have them, but the brain and the body, as you probably know, are deeply connected, and when you affect one, you affect the other. So the distinction is a tad artificial. Nonetheless, medications that are oftentimes used in general medical practice, things like to treat blood pressure or to lower cholesterol, to name some very common uses, or to treat pain, can in fact, in some people, have some pretty significant psychiatric adverse effects, including depression, suicide, mania, psychosis, malaise, dysphoria, odd, compulsive behaviors such as gambling, solicitation of prostitutes, and various things. I mean, it runs the gamut because humans are complicated and drugs are kind of complicated too. So I thought today I would just go over some of those effects. And yeah, we'll move forward to next slide, please. So I didn't really mean to have this slide in the deck, but let's go back to the slide for a second. Yeah, so psychiatric adverse effects must also be monitored with treatments that directly or indirectly affect brain processes. Yeah, in this particular paper, they were looking at Aimovig, I believe. There's a monoclonal antibody treatment for migraine headache, which is interfering with a neurotransmitter substance called calcium gene reactive protein, or CGRP. And there are the paper was discussing potential psychiatric adverse effects of CGRP antibodies. Moving on then to the next one. So it's a gigantic topic. There's a lot of drugs and as you'll see shortly, a lot of them can have psychiatric adverse effects. I figured that it would be helpful to just have a resource of a concise and well-written review article. So this one appeared in British Journal of Psychiatry Advances, and I sent through Jamie a link that you can download the whole paper if you like. Let's go to the next slide. So the notable points I would have come up with these on my own, and Gupta and co-author also did this. So some just things to think about, that if you look in a compendium like Physician's Desk Reference, which assembles all the prescribing information for US approved drugs, you'll find that about 2/3 of them will list some psychiatric adverse effect. Very recently, I learned of somebody who had a adverse effect, believing that this migraine treatment was causing hair loss, and the person's doctor said that doesn't happen. That's not in the list of side effects, and so stop worrying about your hair. Also had a consult that I was involved with where a man started to use metformin, and within a few hours started to have mental status changes that looked like that were just consisting of sedation. And he continued to use the metformin, and by day 3 he was obtunded to the point that his wife could hardly rouse him from his sleep, if you call it that. And he was brought into the emergency department, and the records there indicate that the staff went and they searched compendia of side effects for various medications, and they had ruled out hypoglycemia, and they had ruled out metabolic acidosis, by laboratory studies. So somebody actually wrote that we checked, we considered the possibility that the metformin could be the cause of this profound sedation. But we couldn't find that in any database of side effects, so it's no longer the medicine, which is suspect. I got involved in that case because in the end they thought that this was an exacerbation of his depression and that he should increase his dose of Celexa and follow up with me. it really was metformin side effect. But the point is, illustrating the point, bullet point number 2, when they test drugs, when a manufacturer wants to get a drug on the market, they do clinical studies that altogether will get a few thousand people between all the different phases. When that drug is approved, and if it's a useful drug, like for say lowering cholesterol, that drug is going to be exposed to millions upon millions of users. So if we're talking about a rare side effect, like in the case of the statin drugs causing suicidality or violence, you're not likely to catch that in a sample of 3,000 relatively healthy people without psychiatric comorbidity. But when that drug is deployed at scale across the country to all users, then you're going to start seeing associations between that drug and events of suicidality or violence. And then you're going to have, as happened in the case of these drugs, a sort of vigorous debate in medical journals about that can't really happen because we tested this in clinical trials, yet there is a biochemical plausibility and some temporal relationships that would make you think that that's a real side effect to worry about. So it's a tricky issue because the best data that we have is the clinical trial registrational data, but that has a lot of limitations, among them as well, that we're talking about people who have the disease in question, but not a whole lot of other diseases, and who don't take a whole lot of other medications. So we don't get a really true picture of the psychiatric, or actually of any adverse effect potential for the drugs when they're deployed at scale and are given to people who are very young, very old, very sick, very comorbid, meaning having like a lot of other diagnoses. So not just hypercholesterolemia, but also hypertension, obesity, depression, diabetes, and so forth, and very polypharmacy. So it's a good first draft of trying to understand what the side effect potential is, the registrational trial for the FDA, but it's very, very far from being conclusive. Also, as you know, these trials are done in short term, and medicines are usually used in the long term. All right, let's go to the next slide, please. And finally, just a personal note, I've been doing complicated consultation for like the entirety of my career as a physician. And my bottom line from one of the pearls I'll offer to anybody who listens is that anyone can have any side effect from any medication. And snarkily, I created a hashtag human diversity because it just happens. Let's go to the next slide, please. So what would be some risk factors? So I've established that anybody can have any side effect from any medication, and what we're reading in the prescribing information, or the PDR, might not capture all the potential bad outcomes. So what are some of the factors that may cue you to think I should be more attentive to the possibility that metformin is causing depression, for example? So people that have a lot of drugs, that have a lot of illnesses, that are, like I said, very young or very old, or postpartum, or under a lot of stressful situations, like at the intensive care unit. A lot of the really interesting psychiatric adverse effects of ordinary medicines I've encountered during post-surgical, postpartum, and ICU cases. So that rings true. Next slide. So let's imagine now that we have a person who's been started on, for example, naproxen, BID, for arthritis. And they come back to you in a week and say, I'm starting to have some uncomfortable suspicion, anxiety, and it sounds a little bit like paranoia. What's to make of that? I mean, and let's make it more complicated. And let's say that this person is also periodically uses marijuana, and also is maybe a 25-year-old. So let's make this person, to make it interesting, let's say that you have a 21-year-old man who's got psoriatic arthritis, and you're going to prescribe regular naproxen as an adjunct to pain management. Now he comes back and he's talking about psychotic symptoms, and you have a drug-using guy who's at a prime age to develop schizophrenia, and how do you determine, what is what? So you do simply, you look for, when did I prescribe the medicine and when did the symptoms start to happen? So you get very granular on the timeline. You can wonder, is there some biochemical plausibility? Like, is there a way that prescribing an NSAID could translate into psychosis and to steal from the future? Yeah. To steal from future knowledge I'm going to give you, yeah, blocking prostaglandins actually unleashes dopamine in the brain, so that's a plausible mechanism for NSAIDs to cause psychosis. And yeah, you should try to, in this case, it's difficult to rule out the effects of marijuana or his age, but you consider that, and then notably take the drug away, and does that clear up the psychosis? And then sometimes people will do this. It's a little bit, I mean, it can be done, but it's really clear then if you then reintroduce naproxen and he has psychosis again, or if he takes medicine off the counter like ibuprofen and has the same response, then that's quite solid for causality. Among the best, I'll say this 2 times during this lecture. The best thing that a clinician or a patient or the family member of a patient or anybody who cares about this can do is to make a record that is easy to access and easy to see in one page. I can't help it. Nicole's going to like it. I'm going to digress. The modern electronic health record was supposed to be this awesome thing that'll make everything great. And, as I see this, it really enhances the ability of the people who submit bills on our behalf to collect the income. Because they'll say, these are the symptoms, these are the procedures, these are the things that are met to satisfy the billing code. And honestly, every record that I've seen dealing with medications has been like an afterthought. They typically list them simply alphabetically. Note to anyone listening, if you could design one that clusters medications by pharmacodynamic action, that would be plus. Also, to easily assemble a timeline of here's when medicines were prescribed, so that you can then say, here's where psychosis shows up, or here's where he never stops, he's continuously oversleeping, or there's where the panic attacks show up. So getting just a simple chronology of here's the medicines, here's the symptoms, makes it really easy to begin to put suspicion where suspicion is due in terms of medication causality. Next slide. And so from the paper, the review article which you can access, this is the handy dandy table, worth familiarizing, and I'll go over some of the interesting bits. So again, lots of medicines, lots of side effects. Anybody can have any side effect. So let's talk about cardiovascular drugs. Where to start? This audience, I think, is familiar with using steroids or other kinds of immune modulators, and they reliably have psychiatric adverse effects, and they can range from simple mood things like anxiety or depression to full-on psychosis and agitation. And yeah, isotretinoin, I think, is underappreciated, at least from my view of the clinical practice and consultations and questions I get. Cardiovascular drugs, I think most people are aware that the beta blockers have the classical association with depression, but paradoxically, they also have a fairly good effect at anxiety reduction, so they're not entirely bad, but certainly they can cause something that looks like depression. ACE inhibitors can cause something that looks like mania, believe it or not, and statins, I sort of alluded to earlier, there's a concerning stream of case reports and biochemical plausibility that link them with depression and suicidality. Actually, better quality data looking at biochemical markers are making a firmer case that some people, presumably that have some serotonin metabolism specialness about their genes, interacting with statins lowers serotonin biomarkers very profoundly. So it's a rare thing, but it's a real thing, and I try to explain the plausibility at a first level by consider this: of all the lipids in the brain, and there are a lot of lipids in the brain. I mean, the brain is mostly lipid. Take away the water, and mostly you have fat. Of all the fat in the brain, 25% of that fat is cholesterol. So messing with that one would expect it might do some things. So anticonvulsants have a wide, and one might expect that drugs that are targeted to interact with the nervous system are going to have psychiatric risks. And they, again, run the whole range. I would like to point out this particular one, levetiracetam, aka Keppra, in my consultation with people who already have mental illness. Disasters with this medication are common, frequently causing psychosis and agitation and aggression. Again, anti-Parkinson drugs are designed to get into the brain, so no surprise that they have psychiatric adverse effects. Interesting story with dopamine agonists, the synthetic dopamine, well, there's some natural ones and synthetic ones like pramipexole. When the natural one, bromocriptine, hardly was ever used, but when the new ones came out, they were branded, they were marketed, so they were widely used when introduced. And we started to see these case reports of 80-year-old women who all of a sudden have a fantastic interest in gambling, or 79-year-old grandfathers who've been upstanding citizens who are now like highly interested in soliciting prostitutes. And so, I mean, those are rare side effects, but they make sense because dopamine is a reward signal, and when you start to hit the dopamine receptor, you can get a lot of craving for high reward situations. Antiretroviral drugs are relatively commonly used, and they typically go for depressive-like or anxious-like symptoms as side effects when they happen, but occasionally they can be much worse. Antimicrobials, I really want to call out the quinolone antibiotics, particularly ciprofloxacin. I've had many people admitted to psychiatric wards who basically have horrendous depression following the prescription of Cipro for typically UTI. I'm not sure that I don't have a good lock on how often that psychiatric adverse effect occurs, but it occurs often enough that I would, my advice to all of you is to save that kind of drug for when it's the only thing that the culture and sensitivity results are telling you it should be used for. Great drugs for lots of things, but they're the most risky. Also, there's interesting case reports of azithromycin causing psychosis. I can't really explain to you how those two, the mechanism, but it's well established. Good oral hypoglycemics. I told you that anecdote about metformin. Some antihistamines, cimetidine, rarely used, but it was the first of the H2 blockers for dyspepsia and ulcers. I actually took that medicine for what was going to be an ulcer eventually, and I had firsthand experience. I just felt so angry. I'm not really an anger-prone person, but I was riding with my family to my grandparents' house, and I really just wanted to scream and bite people. Yeah, that can happen. NSAIDs, I alluded to, fabulously interesting literature around psychotropic actions of NSAIDs. There have been some recent reports that link Tylenol to reducing measures of empathy. They have a whole lot of stuff, and it goes down to probably the fact that when you block prostaglandin synthesis, you wind up changing dopamine neurochemistry, and some people are going to be sensitive to that. So very rare, but really interesting. I once gave a lecture talking about this, and some nursing care line manager came up to me afterward and thanked me profusely because nobody would listen to her or take her seriously, that she started to hear voices every time she took Advil. And yeah, we'll leave it at here and move on, I guess. But please refer back to that and think about things. So common ones, some other things that I've seen in my practice that I think are interesting. The anticholinergic drugs change mood. There was a theory back in the 70s that depression is related to an imbalance of norepinephrine and acetylcholine signaling, based in part on observations that anticholinergic drugs tend to elevate mood, and that can go to flat-out mania. There's about 107 medications in clinical practice that have significant anticholinergic action. So but the stronger ones at least keep that as a possibility. So the mania can happen much more commonly. You'll have memory impairments and deliriums from those drugs. Um, it's rare, but it also happens that people who use inhaled steroids for asthma treatment can get psychosis. I mean, it's no secret that steroids can cause mental status changes, typically manias and psychoses. Really unexpected that that should happen from essentially topical use in the lungs. But there are some people who can absorb that in sufficient quantities and get that. Talked about Cipro side effect. There was using that technique of making a timeline of day, in this case it was a hospital patient, so day by day medications and then lines from nursing notes about symptoms. I was able to pick up that trazodone was the cause of the consultation that I'd been called for. Like, why is this person who'd been very well all of a sudden talking about robotic spiders coming out of his skin? And it was really interesting because every time he got his PRN trazodone for sleep, about 2 days later, he would make comments about the spiders coming out. I don't know how commonly it's known, but opioids can, for some people, provoke manias and psychoses, and they're used post-operatively, and that's a setting where you have a lot of other factors which can predispose one to psychosis. So that I've seen happen. And oh yeah, Montelukast, aka Singulaire, can have, I think it's actually in the prescribing information to have about mental status changes, including nightmares and depressions, suicidality, and psychosis. Seems to be a lot more common in kids, but can happen to anybody. So a few things to say around that. Let's go on to the next one. Next slide, please. And so among other risks, I mean, it's good to know that your ordinary, common, ordinarily non-offensive, and ordinarily very helpful medications can cause psychiatric problems. And at least putting that as always something to be suspicious about will help you to avoid what I call the old lady and the fly scenario, which has been a common scenario in consultations that I get. So you'll start off with a medication causes a side effect. The clinician doesn't recognize that the side effect is caused by a medicine. Rather, if it's like in the case of depression, they'll treat it with some antidepressant, which you now have you have a vulnerable person, the neurologically vulnerable person, and you can have then the antidepressant causing its side effect, and then you can have, in the case typically anxiety, so that you can then prescribe another anxiolytic medication, and then you can have some people just get into this cascade of prescribing, and then they wind up being my patient. And so finally, last slide, please. The best thing I can say, I mean, the thing I'd like you to really take home is that anybody can have any side effect from any medicine. When you have somebody who's got a new side effect or a new psychiatric complaint, then please, go over in your head, or ideally keep this kind of record of a timeline to say, did that happen after I started medicine or after something that had been there regularly being discontinued? So in this, in this example, keeping just a record of months, life events, and in this case, hypothetically, you have our patient developed a positive PPT screen for his job as a nurse. Then he was treated with isoniazid, and then shortly after that, started to get in trouble with gambling. Gambling's not usually seen as a isoniazid side effect. But second, again, everybody's different and respect human diversity. And just because it's not listed as a common or known psychiatric adverse effect, it deserves the benefit of the doubt. So that's all I've got to say about that.